Next, we have Dr. Divya Mohanchandran Nair. She's our chief instructor and consultant vitreoretinal surgeon at Await Eye Hospital, Calicut. She's going to talk to us about perioperative considerations in patients with diabetic retinopathy during phacoemulsification.
Good morning all. So let us see what are the perioperative considerations that we will do in a patient with diabetic retinopathy who is planning for phacoemulsification. So cataract surgery is one of the most common surgeries done worldwide, and many of our patients are diabetic patients. So the end result of a cataract surgery for everyone should be a happy patient and an equally happy surgeon. But often this may not be possible, and sometimes we are faced with these kind of unexpected problems, and this may be due to undetected retinal pathologies or a diabetic retinopathy causing sudden worsening. So all types of progression in diabetic retinopathy after cataract surgery have been noted. There is at times development of severe proliferative diabetic retinopathy with neovascularization and end-stage glaucoma, and even CME is said to be more common in after cataract surgery in diabetic patients. So the pathology behind this is postulated to be that there is breakdown of the blood retinal barrier, the blood aqueous barrier, leading to release of inflammatory cytokines, and of course the most important molecule VEGF. So ocular VEGF levels have been reported to peak immediately post-op on the day 1, and it settles down only after 1 month. So how can a cataract surgeon shield themselves is to do a good and thorough meticulous preoperative evaluation and determine that cataract is the only thing that is affecting the vision. So to do a good evaluation, start from the iris, look for rubeosus iris, dilate and see the whole fundus, and especially the nasal retina, because sometimes the posterior pole might look very normal and innocuous, whereas an NVE might be hiding in the nasal retina. And in a diabetic patient, it is always better to do an SDOCT macula. Many hidden macular pathologies can be detected, and especially if you're planning for a high-end IOL like a toric IOL or a multifocal IOL. And after that, give a good counseling to the patient, let him have realistic expectations and how much retinal follow-up he needs after his cataract procedure also. So when a patient has diabetes and cataract, there are following 4 scenarios that can happen. There is diabetes but no retinopathy. There is diabetic retinopathy but no macular edema. There is diabetic retinopathy with macular edema, or there is advanced diabetic retinopathy with vitreous hemorrhage or TRD. So the dictum here is try to stabilize the diabetic retinopathy before planning cataract surgery. So when there is diabetes but no retinopathy, even when there is no retinopathy after cataract surgery, progression has been noted. So here it is very important to follow up and dilate and see the fundus after 3 months or 6 months when the patient comes for follow-up, even though he may be having 6/6 vision. So there might be a diabetic retinopathy progression happening. And of course, when there is macular edema with diabetic retinopathy, diabetic macular edema worsens post-operatively, and the risk of post-operative progression is more if there is more manipulation, vitreous loss, or inflammation. So this is just an example of a patient who had come to us and was posted for cataract surgery elsewhere. In the left eye, as we can see, there are few hard exudate lesions close to the fovea, and SDOCT clearly tells us that there is intraretinal edema, there is a small PED and some subretinal fluid. Even though it is not clear, we have enough clue to counsel and tell the patient what is going to happen post-operatively. So this is another patient, both eyes pseudophakic and has developed diabetic macular edema, and the left eye is a recent post-op where there is severe diabetic macular edema. So in a patient with cataract and diabetic macular edema, we have the following options. We either stabilize the DME with injection before the surgery, or do a combination with phacoemulsification and intravitreal injection, or a focal laser preoperatively when the edema is not center involving. So regarding intravitreal injections, we have good enough evidence back knowledge and multiple molecules available with us. There are multiple anti-VEGFs and biosimilars available. There are steroid like the DEX implant, that is Ozurdex and IVTA. There are multiple studies which compare phacoemulsification with each of the individual anti-VEGF agents. However, there is one meta-analysis which has compared intravitreal dexamethasone implant versus anti-VEGF in a combined surgery with cataract surgery. And this meta-analysis states that in intravitreal dexamethasone implant in combination with cataract surgery provides better anatomical outcomes over a 3-month period compared to anti-VEGF. However, in anatomical terms or in functional terms, both have had equal efficacy. So, and one more thing to keep in mind when implanting a DEX implant in combined cases is if the posterior capsule is compromised, there is chances of migration of the DEX implant into the anterior segment, and then it has to be removed. So, you can give anti-VEGF or steroid. If you are giving anti-VEGF, we have to explain to the patient that he requires further follow-up, multiple anti-VEGF injections even after the cataract surgery is needed. Though the DEX implant may have to be repeated after 4 months. And ideally, it is to be done at the end of the phaco surgery after all the viscoelastic and everything is washed out in the infratemporal quadrant. And if you're doubtful for having any wound leaks, you can ask the surgeon to just suture the wound for you. So when there is diabetic retinopathy alone without macular edema, better document and send for a post-op retina review without fail. When there is proliferative diabetic retinopathy, document and inform the patient, take a fundus photo, and if there are severe fibrous proliferations, better take an OCT to see that the macula is okay. And do a pre-op PRP whenever possible. However, at times when the lens is with severe cataractus, we may not be able to do PRP. In such a situation, do the cataract surgery and do an indirect PRP laser immediately after cataract surgery within 1 week. And sometimes we can add an anti-VEGF along with the phaco and buy time before doing the PRP. If there is severe diabetic retinopathy with subhyaloid hemorrhage and traction and all, then it is also prudent to do a combined phaco with vitrectomy, and this prevents the patient from coming again for a immediate second surgery. And if in a very dense cataract, the fundus is not visible, then try to take clues from the other eye. If there is PDR in the other eye, of course, there will be some kind of diabetic retinopathy in this eye. And always do a B-scan ultrasound before taking up for a mature cataract. At times, diabetic retinopathy can be complicated with neovascularization in the iris or an NVG. In such a situation, do a prompt and aggressive PRP along with anti-VEGF, and the NVI has to be regressed before planning for cataract surgery. The eye has to be quiet before planning cataract surgery. If it is intractable glaucoma, then you may have to combine the phaco with a vitrectomy in case the fundus is not at all visible, and endo laser may have to be given. Or if it is totally bad and there are mature fibrosed vessels in the angle, we may have to combine it with an endoscopic diode photocoagulation. So regarding the type of IOLs in this patient, avoid silicone IOLs because future he may need silicone oil placement, and better to do a hydrophobic, hydrophilic, acrylic IOLs, and monofocal IOL is recommended. So always remember to have teamwork with a retina colleague, and remember it is the patient's problem if we diagnose it before surgery, but if we diagnose it after surgery, then it becomes our problem. So careful preoperative planning, patient counseling, systemic control of the diabetes and hypertension, and close post-operative supervision. These diabetic patients with cataract surgery can have excellent vision. Thank you.
Thank you, Dr. Divya, for that excellent